Okay, hello everybody. Thank you for joining us today at Psychiatry and Behavioral Sciences Grand Rounds. This is our webinar version of Grand Round series for the 2020-2021 academic year, and this is our third presentation in this year's series. I want to say just a little bit about the Grand Round series before I introduce today's speaker, Dr. Focht. Grand Rounds this year, like I mentioned, is occurring through a webinar format. And what we've tried to do is get a group together of advisory panels, including faculty and staff, to advise us on potential speakers to invite for presentations in one of four areas: in education, in clinical domains, in a domain called staff, trainee, and faculty development, and in research. And we've had suggestions and ideas coming from psychiatry residents as well. We have an opportunity to have grand rounds in this webinar format most weeks, and we'll aim for having speakers, either local speakers or speakers from other institutions, most weeks out of the year. We've drafted I've worked on drafting a post-presentation evaluation to get feedback on the series and how we might be able to change it to improve the quality. Currently, that evaluation comes up after you click end for the Zoom meeting. If you have a minute afterwards, please fill that out, and I'll be able to see the results of those surveys. So I'll stop screen sharing for now and can introduce our speaker for today. Today we have Dr. Amanda Focht, and Dr. Focht is a faculty member here in the Department of Psychiatry and Behavioral Sciences at UW, and Dr. Focht is the medical director of the outpatient psychiatry clinic on Roosevelt. And we'll present today about the experience that Dr. Focht led of transitioning the outpatient practice from fully in-person care to almost overnight becoming a fully telehealth practice. And if you have questions for Dr. Focht during the presentation, type them into the chat box, please, and I can help to get the questions answered towards the end of the presentation. And I'll stop for now, and Dr. Focht.
Okay, thank you. So thank you, Jürgen and Joe, for this opportunity. Just going to share my screen here and pull up the presentation. All right, so as Joe said, just talking about our transition from going from 100% in-person visits at the outpatient clinic to almost fully virtual visits. And just in putting together this presentation, it was very interesting just reflecting on everything that had happened. It was a time to kind of take a breath and think about it. So this is me and no conflicts of interest. So this is what we're going to talk about today. Just give you a little bit of background on the clinic, talk just a little bit about what we were doing pre-COVID with telehealth, and then what the transformation was like, some clinical challenges that we faced early on as we're sort of all learning about this, and then switching gears a little bit to talk about future directions and thinking about resident education and supervision in the clinical setting, and also core competencies for providers in providing telehealth, and then trying to wrap all that up and think about what we're going to be doing in the future, which will certainly be a hybrid of things that we've been doing. So as I was putting this talk together, I was just thinking a lot about my training. So I trained in New York City, and I spent a lot of time in offices like this in Manhattan with psychoanalysts talking about things and talking about clinical, care and imagining them sitting and listening to patients who are lying on the couch. And it's sort of looking at these pictures here, which is actually from a photography book of a psychoanalyst who took photographs of his colleagues' offices and published them. I was just struck by how different things are now, I think for better and for worse. I will say that there was kind of this sanctity of those four walls, and I've always thought that the psychiatric consultation room is similar to the OR in some ways, and in that when the door is shut, it's really about us concentrating on the patient and trying to help them. And so in that spirit of just trying to bring that same just privileged perspective that we have in working with patients to the virtual realm. So when we talk about telehealth, we're not just talking about Zoom. We're talking about all types of health-related technologies, and so that can be video conference. It can definitely be telephone, as a lot of us have realized with those of our patients who just don't have capability to be on Zoom, and phone was easier or preferred. It also has sort of developed for us that once we start using one of the technologies, the patients expect that we'll be using kind of all the technologies, meaning that why can't they just email us more easily or text us? And that's a big one. Or have other ways of reaching us. And as we get away from being in our offices with Xerox forms to hand out to patients, how do we integrate apps into our care and other electronic technologies? And so these are all things we're thinking about going forward. So just a little bit of a background to the clinic. So we're located at the Roosevelt location. We have 7 attending psychiatrists and 4 attending psychologists. We're a primary training site for both the psychology residency and then also the psychiatry residency. And so we have R2, R3, R4 residents who get what I think is a really, really top-notch education in delivering evidence-based psychotherapy. It's not something that I was exposed to such a degree at all in my training. And so it's really good to see them learning that. And then also just managing general psychiatric conditions in the outpatient setting. We also have clinical electives. We've moved, Kate Comtois has moved the resident portion of the DBT program over to the clinic. We have a perinatal psychiatry elective and a new geropsychiatry elective, as well as an assessments elective. Our patient population is largely commercial insurance, but there is quite a mix, and we have a cohort of Medicare patients that have difficulty getting care elsewhere, as well as a share of Medicaid patients. So just broadly speaking about the department and how telepsychiatry sort of fit in prior to COVID. So this was exclusively clinic to clinic, except for the VA, which had been doing telehealth into the home for a long time. It was a consultative model, so there was no prescribing, there's no ongoing care, and it was really designed to just increase access in remote areas and increase our reach. I did a telepsychiatry clinic into San Juan Island for about a year, which was my first experience delivering care this way, and was really helpful in having that experience going forward. So we were moving towards a telehealth into the home rollout prior to COVID. And we were envisioning it as, kind of a pilot, a slow and steady phasing in. We recognized that telehealth was definitely going to become part of the way that we delivered care because patients really demanded that. And in order to remain competitive in the marketplace, we needed to deliver care this way. And so we felt that a good way to get our feet wet with it would be to start small, know the patients that we were going to be meeting with in this way so that they were low risk. It was we were going to initially choose patients who it was just more convenient for them to use the technology because it was hard for them to get away from work or childcare responsibilities. And of course, we were going to ask people who were comfortable using the technology if they wanted to do care in this way. So in February 2020, as we all are living through, this was our scenario. So basically we had been meeting and we're sort of ready to almost launch our first pilot of that telehealth into the home when COVID happened. And as I was putting this slide together, just sort of thinking about what it was like at that time, it's just kind of amazing to me the numbers that are on this slide about the number of cases and just, you know, how I don't think no one could predict like where we are now with COVID and just all of the changing, you know, landscape that we're all having to live in, ourselves as providers and our patients. So as COVID hit and it got really confusing at the clinic and the hospital in general, like how are we going to deliver care? How are we going to make the clinic a safe place for patients and for providers? And this was really acknowledging that our patients were going to go through an unprecedented time. Loneliness, isolation, grief, financial stress, all of these things, and our colleagues as well as ourselves, and just kind of bracing ourselves, trying to figure out how we were going to move forward. So everyone was apprehensive about coming into the clinic. Patients, residents, staff, and it was also, there was rapidly evolving messaging, and that was because there was rapidly evolving knowledge about how to create safety in the clinic setting. And given all of these things, there was a push to go ahead and launch our telehealth program. So this was the basic timeline, just, and it is, you know, kind of amazing to look back. The first COVID case identified in the US, and then jumping to the first death, and less than about 3 weeks later, almost a month, we launched at OPC, and that was converting, I'd say 99% of the visits over to virtual visits. So what was that transformation like? Well, it was very tumultuous. So instead of having this kind of carefully designed pilot program with a carefully curated patient population, we suddenly were opening up access to all of our patients, including the very complex, those who are high risk. In fact, it was very, very important to open up access to patients who we thought could be struggling the most with what was going on. And the majority of visits we were doing were into the home. We weren't seeing that many patients in person, although we never did close the clinic. We always saw some patients there. And the majority of our providers were at home for a period of time. Our clinical supervision of residents switched to virtual, and we started providing our ongoing care to patients in this way, not just consultations. We were seeing new patients that we'd never met in person and seeing them even using the phone, not even using video. We were prescribing controlled substances because the regulations had been relaxed. And we were also seeing patients who were traveling for various reasons, were stuck places as those regulations were relaxed as well. So prior, as I was putting this talk together, I sent out an email to my colleagues and just asked everyone for their thoughts about what this experience was like for them. So telehealth was new for almost everyone. Some people had done a little bit. No one had really done very much. Everyone pretty much agreed that, the transition was rocky at first. It was just it was a pretty steep learning curve, just having to learn the technology and just, sort of pivot the clinic. And We started having concerns about access disparities from the very beginning, realizing that there were patients that just didn't have access to this technology or didn't know how to use it, and trying to figure that out. But then there were silver linings as well, gaining a lot of time back from commuting for patients and for all of us as providers, but also acknowledging that we miss being in the room with patients and that it is different to do virtual care than it is to being in the room. We were able to expand our access because of the amount of time that we were able to recapture, which was gratifying. Supervision, on the other hand, was challenging. Getting the residents launched with their virtual clinics, and just not being able to have that in-person supervision experience with residents. Everyone missed seeing everybody else around the clinic, certainly, but for some, work-life balance became a lot easier, especially as we had children who were at home. I think a lot of us have acknowledged that at times the virtual visits can be more draining than in person, but everyone would not go back. I mean, everyone said this is sort of where we are now, and we have to move forward from this, and doing a hybrid model or a way of integrating telehealth into our clinical care is just what we're going to be doing from now on. So we had some early clinical challenges. And, you know, like anything in medicine, you have to get some clinical experience with things. You can't just kind of predict or think algorithmically about what might happen. Scenarios just have to come up, and you have to figure out how to deal with them, and then try to create a systematic way of doing it better the next time. So we had one particularly challenging case with a patient who was new to the provider who was seeing her, who had a remote history of anorexia and had really decompensated, and her insistence on phone visits kind of complicated the care of that patient. We had some concerns around patients who were in domestic violence situations and just ensuring their safety, because the uptick in domestic violence concerns just in the pandemic in general, and also because we couldn't ensure privacy for them when they weren't coming into the office. We all talked a lot about what would happen if we had an emergency with a patient and had to send emergency services out, but that thankfully hasn't happened yet, so we don't have a lot of experience in what that is like. The VA does have experience with that and has been very helpful in counseling us and sort of helping us begin to think through that and create some protocols. We also realized that our patients were experiencing a lot of challenges clinically because they couldn't get out. It's very difficult to design behavioral activation plans when everyone's stuck at home. OCD patients were suffering, those with contamination concerns. And there was just a general increase in symptoms and also increase in need that everyone had. So looking at sort of how we did financially, we did pretty well. I mean, this is a comparison of where we were in fiscal year 19, and this is looking solely at RVUs. So it doesn't look at reimbursement, and reimbursement is, sorting itself out as payers decide how they're going to reimburse telehealth services, although there was an acknowledgement and an expansion in the way that those services were being reimbursed. But if we compare April to June in these 2 years, 19 to 20, we were pretty competitive with ourselves, which was surprising to see because we were so caught up in the moment. I mean, I definitely felt like we were busy, but it was gratifying to look at the numbers and realize that we really were delivering care. And then looking at how the departments did compared with other departments across the institution, did pretty well. This is looking at just the budget variance in 2020 compared to the prior year, and psychiatry was only a little bit down, and some of that had to do with delay in getting payment for as the billing all got more complicated. But other departments had a harder time, and it's understandable that if you're an orthopedic surgeon and doing elective surgeries, that you would take a big hit during this time. But we were able to pivot and remain, pretty financially solid, which was also gratifying. So in thinking about resident education going forward, so this is, one of our core missions at the clinic is to educate our residents. And it's definitely been a challenge during this time, just because of all of the changes that have gone on. It's hard to teach something that is very, very new to you yourself, and also to create that kind of sense of community and connection that's so necessary in resident education. So I looked a little bit at the just the history of telesupervision. And so this means just supervision that's virtual. It doesn't imply care that is also virtual, that the resident is delivering virtual care and also being supervised virtually, that there really is no evidence base for that at this time. It's developing, but it's very early on. But telesupervision was developed primarily in rural practice settings, and there isn't a lot of rigorous research about it. And it has generally been indirect supervision, meaning that the resident would see a patient and then receive supervision at a later time to discuss the case. So again, the literature review is pretty limited. Trainees were satisfied with it if that was kind of the only alternative, but there hasn't really been, there's a literature being created now, but previous to this had not been a literature about kind of this situation that we are in at this point. And just in thinking about levels of supervision, which is something that we do, I mean, it's part, these are defined levels defined by the ACGME that defines indirect supervision, indirect with direct immediately available, and direct. So we had been doing a lot of indirect supervision at the clinic for a long time. Our residents would see their patients, and then we would meet days later and talk about the cases. Indirect with direct immediately available is also what we were doing most of the time, because it basically means that there's an attending supervisor that is just a door knock away, to get help. So trying to create that access for residents to their supervisors while everyone is in kind of a far-flung location was a challenge. And then direct supervision, which we had been trying to increase in the clinic for a variety of reasons. It's a win-win basically for everyone. The residents get just more on-time supervision and teaching if you're seeing patients with them. It's a time saver for faculty because they can get some help with documentation and other care things if they're kind of sharing care with a patient. And you can also bill for those encounters, which you can't bill for encounters that are indirectly provided. You can't bill the professional fee. So as we were kind of putting together, and this is also the work of Anna Ratzliff and Laurel Pellegrino, who worked tirelessly to think about this, and all putting our heads together about how things were looking. So we did have some good success with direct supervision. It's really efficient to directly supervise virtually over Zoom, basically, because the resident can get started with a patient, and you as the attending can be working at your desk. Resident will text you when they're ready for you to join, and then it's just a click away to join into the room. And so it doesn't, previously when we were doing this at the clinic, it just involved kind of walking around the halls and trying to figure out when someone was ready to be seen and this kind of thing. So it really flowed quite well. That's one thing that I think is in some ways working better. I mean, it doesn't mean that we won't go back to some direct supervision with in-person visits as well. But virtual supervision is definitely a challenge. It's hard to, as we've all, had experience of, just engage a group sometimes over Zoom to get conversation flowing. And, with resident education, so much of what is happening in those group supervisions is just residents helping other residents, and you're saying, that sounds really hard, or this happened to me. Just a lot of normalizing about things, and that's harder to do over Zoom. So as we go forward and thinking about just providing supervision and what we're going to be doing going forward, I think it's just important to consider what defines good supervision in general, which means solid goals and objectives, figuring out what the structure is going to be in advance, how you're going to be communicating, and some of the nuances there, building in-person meetings as we go forward. I think that having access to a virtual supervisor is a really good thing. If a resident's on a different rotation, they don't have to leave that rotation. They can meet with that supervisor on their lunch break. So it works well. I think it's also could be important to build in some in-person contact, and it's just a matter of deciding kind of how to do that. Just figuring out how you're going to communicate is really important, and then also figuring out what you're going to do if the resident needs help, how they're going to get in touch with you in clinical emergencies. So we're also, as we think about going forward, thinking about provider core competencies. And the idea of core competencies is one in which we are breaking down the domains of how we teach something. So the domains of knowledge, skills, and attitudes. How do we state specifically what are the knowledge, skills, and attitudes needed to deliver good care over telehealth? And this was something that happened over the summer at our clinic, as we were lucky enough to have new faculty join us. And they came in at this time, there's all of this flux and change, and what we were doing at that point was mostly kind of experiential. We had obviously some guides and things that we had put together, but it was all, we had just been kind of running on momentum, and we knew what we were doing, and we were conferring with each other about it, and then sort of bringing someone new into that mix and orienting them to telehealth just made me think more about these core competencies. And that's something that, in collaboration with Cara Towell and others who work at telehealth in the institution, we've started thinking about as we go forward, just defining these core competencies more and more. So one way to break down the competency domains as they apply to telehealth, and this comes from the Coalition for Technology in Behavioral Science, which is an organization that is devoted to sort of the research and promulgation of technologies, and came up with a task force that took this on. Basically, how do we think about these competencies, and how do we kind of break things down? And so they saw 4 broad areas here: clinical evaluation and care, telepresence in the virtual environment. Means basically, how are you coming off as a provider in this format, and what is the virtual environment for both you and the patient? Technology, obviously being really, really important to ensure reliability, privacy, access disparities, trying to figure those out, and then of course legal and regulatory issues around all of these things. So when we think about that first one, clinical evaluation and care, and we think about in-person and telehealth, there are things that are definitely different. There are things that are the same. So certainly the history taking can be very similar, needing to develop a rapport, needing to provide, a standard of care, obviously, of what you're doing, and realizing that when you're creating a doctor-patient relationship, you have to provide, care as you would to someone if they were in person. That doesn't change, but there are some big differences. Physical exams are challenging, and we've encountered that with patients with needing their Ames assessment, getting creative, trying to do that virtually, but also I started bringing, as this has all continued, we haven't transitioned back to as much in-person care as we likely will when the pandemic is over, or eases at least, where I'm starting to bring back my patients who were on antipsychotics to do an Ames in the office. It's also the challenges of getting blood pressures and things like that. Getting assessment materials to patients. Luckily, our PHQ and GAD have been embedded into Epic, which really helps. But there are a lot of other assessment materials that we like to collect. And again, it's not just that, reaching into your file drawer and pulling something out. It's now, how do you get this to the person, attaching things over e-care messages and texting and emailing and all of these things. What is an efficient way to get that done? Responding to emergencies, as I mentioned earlier. Questions about boundaries and appropriateness as we have these very intimate views into our patients' homes and their lives, and in some cases they have views into our homes, and also just dealing with technical difficulties. So some things that we've realized and sort of putting together as our key points and a view towards understanding how to deliver this care. Really, really important to verify address and emergency contact information in the EHR. Definitely had some patients who come up as having just PO boxes in there. And so really important to know where your patient is, and to be able to dispatch emergency services if needed. It's helpful to be assiduous in just understanding who are the members of the care team for your patient. In the example of the patient with anorexia that have been challenging for us to treat, the psychiatrist is able to work with the patient's primary care doctor, who was able to get the patient in person. So the collaboration between the two of them, they were able to help that patient. And just developing joint plans, making sure that consents are in place to speak with family members and involved others. This is always important, but can be especially important if you had an emergency situation and you're not co-located with the patient, and you need to know if there's somebody else who could go to the location or could help. Really important to ask each visit where the patient is. We've had patients calling from Mexico City, a patient, popping up literally on the streets of New York, various things like this. And there's been some relaxation of regulatory requirements about our providing care only in Washington State, but those are now contracting again. And so just being clear about where the patient is physically located. Patients don't really understand this, and it's understandable because they feel like, well, I have the technology, I can talk with you. Why do I have to be in Washington State? So having conversations around that, making sure that we're asking about domestic violence so that we can just be mindful of those patients who may be at increased risk. And it's been helpful to have crisis resources that are just easy to cut and paste into the chat or to text using ZipWhip, which is our HIPAA compliant text. And then seeking case consultation. So these are all elements of good care in general, but I think case consultation, whenever you're doing something that's very new, it's just really important to collaborate. We've been able to establish a meeting among the attendings at the clinic that's better attended than it used to be because it's easier for people to attend over Zoom. And so that's been really nice to be able to talk about our experiences and our patients in that way, and then, you know, consulting with legal and risk as needed. So just a little bit more about our safety protocol. So I worked with Brad Felker in coming up with our first sort of proposal for telepsychiatry into the home, and developed a few things that have definitely been helpful. Having a dot phrase that drops right into the clinical documentation that prompts us to remember to ask about the address and emergency contact. Explaining to patients that if there is an emergency that you will have to dispatch emergency services is really important, just so that they're clear and they understand that. Discussion about how do you access emergency services if you're not in the same location? How do you get access to another county's emergency services, for example? And also helping the residents deal with their patient emergencies. So previously they would be in the clinic and there was always an attending present and they could go and find that person and interrupt them if needed. But now with everybody practicing in different places, making sure there's a very clear, there are very clear guidelines for them about how to reach someone if they need them. So switching gears a little bit and talking about that second domain in the core competency, this telepresence in the virtual space. So again, this is thinking about both the patient and the provider and the physical space and the behavior of both therein. So in the provider physical space, again, just some things that we've included in our guide, that it's just really important to make sure that your camera is not at a weird angle, you don't have lighting issues, especially being backlit. I have a big window in my office, and so I have to remember to shut the blinds or I just appear in silhouette and looks weird. Making sure your sound works, people can hear you, of course. One that is always distracting is just, you know, sitting in front of my computer. I always interacting with my computer in some way when I was meeting with patients generally, but now I'm staring at it. And so all of the, you know, email reminders and all of this kind of stuff, just making sure that that is disabled so that I can really focus, you know, on providing care, making sure that people understand that I am delivering care and are not coming into the space where I'm delivering that care. All of that stuff is really important. And then when we talk about provider behavior, this is a little bit hard to read, but this is the sort of adage of not having to wear pants if you're doing anything over Zoom, which is not necessarily a good thing. So you just want to maintain, you know, professional demeanor, of course, and I'm going to start building in doing a test visit with colleagues when they're practicing from home. I've done that, had other people help me with that, of just take a look at my space and me sitting in it. Do things look okay? Is there anything, you know, sometimes there can just be things that others notice when they're looking at you over Zoom that you might not notice yourself. Just appropriate dress, it's really important. The whole thing about looking at the camera is important, and arranging your screen so that the patient, you can see them, you're kind of looking at both at the same time, but realizing that you can't look at the image of the patient or it looks like you're not looking at them. Just being expressive, it's just different talking with someone over the phone or over video than being in the office. It's not as easy to pick up on subtle cues you might be giving, just about, you know, empathy or understanding or anything like that. Speaking clearly, and the pause thing, you know, sometimes it varies just depending on what the connection scenario is in a given, but you have to just make sure you're waiting so the patient has a chance to respond so that you're not speaking over them, and again, not getting distracted. And when we think about the patient physical space, it's for me really been about trying to be tactful and suggesting that they could change something because they've made the decision that they want to be seen in, whatever space that they're calling from. But some things that have been challenging is just a space that's clearly not private, where there are other people just kind of coming in and out, and it's unclear, who they are, or what's going on, or it's roommates or partners. Patients who kind of are electing to turn the camera off even when they have that technology available, and just encouraging them to turn it on because it is helpful to be able to see people visually. Patient behavior. There's definitely been a lot of patients just having woken up and calling in for their appointment. So just tactfully saying, oh wait, let me just give you a few more minutes so that you can get ready for our appointment today. Just, issues of substance use, that hasn't come up for me in my practice, but it's something that I talked to Brad Felker about in the VA population of just, I'm sure it will come up at some point for me, but patients who may have been using and having to decide sort of how to handle that and to direct them to, you're going to meet with them again, when they're sober, but also attending to them at that time. The camera angle can be quite jarring sometimes when people are using their phones because they might be holding it in sort of a casual way or some way, and you're just not seeing them, and it can be kind of strange. And also just encouraging patients not to get distracted by the same things that are could be distracting to you. So just taking a deep breath. That was a lot of information, but thinking about where we are headed with all of this, with the acknowledgement that we've changed a lot and we're definitely not going back to the way things were done before. So what are we doing as we go forward to guide ourselves? And so thinking about kind of a hybrid model, what are we looking for? I mean, I think for me, access is such an important issue, I think for all of us. Making sure what we're doing is evidence-based and acknowledging that the research is going to need to catch up to what we're already doing. Definitely engagement of underrepresented and underserved in our communities, and just making sure the care is patient-centered, time-saving, revenue-generating, flexible. All of those things are definitely easier in some ways with the flexibility to deliver care in the way that the patient feels that they would like the care to be delivered, and in a way that we feel is going to be helpful to them. So as we go forward, some questions that we've been asking ourselves. Who decides what type of visit you're going to have? Is it the patient, the provider, both? What do we really do to ensure equitable access? Access disparities can grow, and patients can have issues with access that they are not sharing with us, and we need to have good systems in place to make sure that that's not happening. And remembering that those who don't have access to technologies tend to be really vulnerable patients. And again, what is the evidence base for what we're doing? So these are some future directions. We're developing these core competencies and updating our trainings and our guides. We're continuing to refine the teaching and supervision strategies that we've been, that I talked about earlier, just trying to figure out sort of the right balance of having residents come into the clinic versus not. Continuing to refine our emergency protocols so that there's something that's just really clear that's written down of like what to do in this situation. Continuing to integrate, these other technologies into our care. And again, identifying the ways to figure out if there are disparities, and continuing to add to the evidence base. And so I included these pictures here. So this is one of my favorite museums. It's the Museum Art et Métier in Paris, and I lived right by it for a period of time. It's kind of like the Labor and Industries Museum here, and so it has all these early technologies. So this is a little bit hard to see, but this is an early flying machine, and the idea behind it was that it was supposed to be like a bat, constructed like a bat. And so if you can see this, it looks kind of like a bat wing. Very, very beautiful and elegant. Not super practical, I think, in sort of production. And then the propeller-driven car. So pros of the propeller-driven cars, apparently it doesn't need a transmission because it just has a throttle. Cons, really windy if you're driving in it, and also very, very dangerous if you're a pedestrian. And so I add these as just kind of a tongue-in-cheek way of saying, like, it's really, really fun to be creative. And I think as we should think big and have creative ideas, and we'll continue to refine them over time, just all working together as we tend to do in the department. So that is my talk.
Hey, Joe, I'm going to make a few comments. First of all, Amanda, this was a really fabulous presentation. Thank you. And it's a hard one to do because you're talking about stuff that's not in the past. You're talking about right now. This is stuff you guys are doing right now. So it's real time. And in addition to being well done and really kind of inspiring, it had a whole bunch of great practical tips. I'm also converting some of my patient care to telehealth. And this is new for me as well. And I wrote down a whole bunch of stuff that I need to look into more. So thank you. It's tremendous work that you and your colleagues have done in a short period of time. I think that means you have a lot of courage. You seem very resilient as a group, and I want to congratulate you on that. I think there's obvious to anybody who would listen to this that there's been a tremendous amount of growth. I hope it's not all traumatic growth, although some of it may have been traumatic growth. But clearly a lot of growth. I'm super proud of what you all have accomplished. Probably the thing I'm most proud of is you never abandoned your patients. In fact, it looks to me like you actually improved access during this very challenging time. And I just think that's really wonderful and inspiring, and I want to thank you.
Jürgen, I was intending to call on others for questions. Do you have a question that you want to pose?
No, I have one more comment. I've also, the space you all are practicing in, I think I was one of the first faculty to move into that space in the mid-1990s. I was in room 320 down the hall from where Dave Dunner was practicing, and we were doing our work, and we were doing very traditional supervision the way you described it. We had a once-a-week supervision group where we got together with the residents, and people sort of selectively talked about stuff they had done with their patients, but there was just a lot that we never saw, that we never heard, and it wasn't direct. And it's interesting that it's 25 years later, and now all of a sudden we have a technology that allows us to actually hop into a patient session. And that's changed for all of us, but I think it could have a lot of upsides. So I thank you for embracing that. The only other question I had is, I've done a lot of work with geriatric patients, and early on, we had the opportunity to do some home visits, and it was a very different experience when you're in someone's home. You're not exactly doing a home visit, but you're sort of going into their home, and you have the possibility of a family member participating in all or some of a session. And sometimes that's really helpful, and sometimes it can be a real problem. Obviously, it's not a good or a bad thing. Could you say anything about your experience with that so far?
Yeah, actually, for length purposes, I actually cut out a clinical example, but it was precisely that point of a patient who her care was upended. She had been in a adult day program, and then it closed because of COVID, and her husband was going crazy with her at home. And he wasn't able to get her anywhere to meet with anyone. And so we were able to meet with them virtually and be really helpful. So that was really good. Some things that have been hard is it's just been harder for older patients with the technology. And so just affirming use of the phone with those patients, I think, has been important.
Right. Yeah, and sometimes it can be really challenging because if you're in their home, you're on their turf. And if the daughter-in-law keeps walking in during a session and wanting to participate, sometimes you got to say, okay, could we create a boundary here, right? So it's not always all good. It creates new challenges, but I think it does create some opportunities because, a lot of us, our patients all have issues that revolve around their families, and it's very difficult to really do family therapy. This creates an opportunity to maybe say, hey, do you want to bring this family member in for a small portion of a visit next time we do it, right?
Yeah, absolutely.
Right. All right, that's all I have. I'm sure others have questions as well.
Amanda, I wonder if I may pose a question.
Yes.
Have you been asked by other clinics within UW or elsewhere to see patients in their clinical sites as a consultation model? Has that come up?
You mean like
rather, yeah, if a clinic was referring a patient to the psychiatry clinic, have other clinics said, well, the patient's here today in the clinic, could you just see the patient now in our clinic?
Oh yeah, no, that's an interesting question. That sort of comes up a little bit with BHIP as we realize that sort of our boundaries are blurred now. Like Mark Duncan practices in BHIP, and then he also practices at OPC, but all the patients are kind of the same. And so we haven't had that specific, like the patient is here now, but we've had more opportunities, I think, in some of the clinics just to be more flexible of where the patient is going to be seen.
I see.
That makes sense. Yeah.
Well, there were several comments in the chat box. I wonder if anyone who wrote in a comment would want to turn the comment into a question. Let's see, a new message. Okay, let's see. Dr. Amrita Bhatt, agree with direct supervision being a win-win and have used the model in perinatal psychiatry. Dr. Bhatt, do you have a question about that? Or let's see.
Laurel brings up a good point. The in-office aims is stymied by the mask, which is true. Yeah. Okay.
Does anyone have another question to type in? Yeah. Thank you for the present. Okay. Here we go. By Dr. Carlson. How have you navigated issues with hearing problems?
Yeah, that's a really good question. We have not done that very well, I would say. I mean, it's something that we're still kind of working towards. So I've had a couple of patients who I just tried to work with individually about helping them, troubleshoot their hearing aids and get hearing aids when they hadn't had them previously. But that's been an issue. We had a patient who has difficulty speaking because of a previous cancer surgery, and trying to, figure out the best way for her to be seen. So that's one of those definitely things to consider, work in progress issues.
Okay, well, if it looks like that's the final question for today. Thank you everyone for joining us. Thank you, Dr. Focht, for this presentation, for describing the work that you've led and that you've all completed. And we'll plan to see everyone back in 2 weeks for the next presentation in our Grand Round series.
All right. Thanks, Joe. Thanks, Jürgen. Thanks, everyone.
Bye.
Bye.